Hello, and thank you all for joining us. My name is Ashley Mateka. I'm the Executive Director of Creative Healing for Youth in Pain, also known as CHIP. Again, thanks for joining us for CHIP's October webinar, More Than Just a Headache. We are pleased to have Dr. Hannah Shapiro as our guest expert today and Dana Pachelski as our moderator. Dr. Hannah Shapiro is a board-certified child neurologist and headache specialist. She's an assistant professor of neurology at the University of California, San Francisco School of Medicine and an attending physician in child neurology at UCSF Benoff's Children's Hospital. She's the director of the upcoming Pediatric Headache Wellness Center at UCSF Benoff's Children's Hospital, Walnut Creek. Dana Pachelski is a member of CHIP's board of directors, as well as the board of the UCLA Resnick Neuropsychiatric Hospital, and is vice chair of Cedars-Sinai Board of Governors. She is also the vice chair of the USC Parent Leadership Circle. Thank you both, Dr. Shapiro and Dana, for joining us today. Before I turn it over to Dana, I'd like to ask that you please consider making a $25 donation to CHIP using the link in the chat if you find this webinar helpful. Thank you again for joining us.
Thank you so much, Ashley. Thank you, Dr. Shapiro, and thank you all for joining us this morning. We are so grateful for your time, Dr. Shapiro. I mean, talking about headaches is such an important topic, and as we all, any of us have experienced headaches, to know getting in to see a doctor, let alone getting somebody like you to sit here and concentrate on a conversation like this, is invaluable. So all of us at CHIP and everybody who's joined us today, and all the people who will join us on our YouTube channel later, we're so grateful for you. Thank you so much. So we have a lot to cover today. I really want to start by talking about headaches. Headaches being pain in the head, migraines. What's the difference? If not all headaches are migraines, I think it's a really good jumping off place for us today.
Excellent. Thank you so much for having me. I'm really excited to be here and talk about such an important topic with you all. And I think that's a great place to start. So, what is migraine and how is it different from quote unquote a typical headache? So migraine we think of as an inherited disorder that produces head pain, but it also has a lot of other associated symptoms and effects of a lot of other systems in general. So in addition to head pain, it also affects the GI system and produces nausea and vomiting. It can affect other areas in the brain, producing sensitivities. So sensitivity to light, sensitivity to sound, sensitivity to smells are all very common. It can affect the vestibular system and produce feelings of being off balance or dizzy. And it can affect even higher areas of cognition. So when you experience a migraine or a migraine attack, it can decrease your ability to concentrate. It can produce brain fog. So it's so much more than just a headache. You have all of these other regions of the brain that are affected and these other systems that are involved. So when you think about migraine, the other kind of type of headache is called a tension type headache. And a tension headache is what you think of as a more, quote unquote, regular headache. These are typically described as more mild to moderate pain in the head, oftentimes described as this squeezing sensation, like a band is wrapped around your head. And there's often not a lot of other associated symptoms with the headache itself. Tension headaches usually don't produce a lot of disability associated with having tension headache, versus migraine is typically this moderate to severe pounding head pain that has nausea, vomiting, light sensitivity, sound sensitivity associated with it. And it's important to make this distinction between these two different types of headache disorders because we think about them in different ways and we treat them a little bit differently as well.
Are there any different warning signs that one should be paying attention to as a headache starts to come on? Anything that you've noticed, with the abundance of people you've worked with, that would be a great thing to say, oh, this is more than a headache, more than just my whole body being experienced in this process, but time to really schedule that doctor appointment.
Yeah, I think anytime the headache is prohibiting you from being able to participate in your normal daily activities is a good idea to kind of a tip off that something more is going on. So oftentimes people who experience migraine, they will frequently miss school. They will miss, sports or activities that they used to enjoy doing because of the headache and the experience that they're having. So I think that if those symptoms start to get in the way of your everyday life, that would be a great time to make an appointment to be seen.
And I like that you differentiated between the whole body process and just pain in the head. So we know that one's more of a tension headache and one really is more of a migraine. And once somebody realizes this and they've gone to see a doctor, what is the diagnostic process of finding out what's going on in the brain?
Yeah, it's a great question. So when you come to see a neurologist, you might expect to have all of these different testing done in order to make a diagnosis. But the diagnosis of migraine is actually what we call a clinical diagnosis. So you don't actually need to undergo extensive testing in order to make the diagnosis. The diagnosis is made based on the history that's taken during the visit. So your doctor will ask you a lot of different questions about how does your headache feel and what are the symptoms that you're experiencing during these attacks. And then based on the information that they gather, they can make the diagnosis that way. So the diagnosis of migraine includes these episodes of headache that are at least moderate to severe in intensity, oftentimes described as this throbbing or pounding quality to the head pain. In adults, it's oftentimes one-sided or unilateral, though in younger patients, in children and teens, migraine tends to be bilateral. And then you have these associated symptoms of nausea, sometimes vomiting, and light and sound sensitivity. And the constellation of those symptoms is what makes the diagnosis. The other important part of the diagnosis of migraine is making sure that there is a thorough neurologic examination that is done. So your neurologist will do a series of maneuvers to make sure that all of the nerves in your face and the nerves going out to your body and the muscles and everything are working appropriately. And there's no signs that something else could be going on and contributing to the experience of head pain. And once you have those clinical criteria and a normal neurological exam, then you can make the diagnosis of migraine.
Such an interesting place right here to talk about, how our head gets in the way of our head. How we actually, without a diagnosis, right? Let's just say somebody comes to see you and they go through this whole process and they know they're having these really big episodes. And then you say, oh, it's just a migraine, right? There's this whole emotional response like, no. And how does that really affect us? How does the autonomic nervous system play into this? Because that's a common process during this.
Yeah, absolutely. And I think that, when you are experiencing something so debilitating like migraine, coming to the doctor and having them tell you that it's just migraine doesn't feel very good. So I usually try to not use the term just migraine because migraine is this whole experience that somebody is having. And to use something like, oh, this is just a migraine or you're having just a headache, it doesn't fit with the patient's experience of what is happening inside their head and inside their body. So I think that, explaining that there are these very real and biological underpinnings to migraine, and it's something that is real, that's happening inside your body, can be very validating for patients because migraine is what we call an invisible disease, right? If you look at somebody, you can't tell if they have migraine or not. And it's really based on somebody's experience of the pain that they're having. So I think it's important, as a doctor and somebody, making the diagnosis is to really validate their experience of what is happening. And I think to kind of talk a little bit about the autonomic nervous system and the role that the autonomic nervous system plays in migraine is important because, so in the very basic sense of the autonomic nervous system, we think about the, fight or flight response. And the autonomic nervous system controls a lot of the, muscles and systems in the body that we can't just control ourselves. So, as opposed to moving your arm, and you can control if you move your arm up or you move your arm down. The autonomic nervous system is kind of one step removed from that. So it's, what happens when you're feeling nervous, your pupils dilate, or maybe you're feeling anxious and your heart is beating a little bit faster. All of those things are the autonomic nervous system. And we know that in people who experience migraine and people who experience pain in general, their autonomic nervous system gets kind of ramped up. And when that happens, it makes it more likely for you to have a migraine attack or experience pain in a different way.
And it's such an important thing that's going on right now. And we can come back to that a little bit later, because right now I feel like it's really important to talk about what's happening in the brain when somebody gets a migraine. What are we seeing, and what do we know, and what can we do, if anything?
Yeah. So what happens in the brain when you have a migraine attack? So there are all of these nerve endings that are in what's called the peripheral nervous system. So if it's outside of the brain, it's called the peripheral nervous system, and it's inside the brain, it's called the central nervous system. So what happens when that migraine attack gets generated, the peripheral nerves get activated. And when that happens, they send signals to something called the trigeminal nerve, which is this giant nerve that sits right in front of the brainstem. And when the trigeminal nerve gets activated, it releases what's called like pain-producing substances. And those little molecules send signals to the brainstem. And the brainstem is kind of that lower bottom part of the brain, and it acts as a gatekeeper. So when the brainstem gets turned on through these pain-producing substances, it then sends signals to the brain and tells the brain, I am in pain, I'm having a migraine. And then that subsequently can activate other areas of the brain. So that's why, you feel this sensitivity to light and sound. If it activates parts of the brain that are involved in nausea and vomiting, you can get those symptoms with migraine. And it's interesting because, so when that happens, you get this migraine attack. And what's supposed to happen in the brain is the brainstem should turn on and off. So when you think about somebody who has migraine, or when they're first developing migraine, we think of it as an episodic disorder. So you have a migraine attack, the migraine attack goes away, and you don't have a migraine for a couple of days, and then maybe the migraine attack comes back. So what happens though is the brainstem turns on when it gets those pain signals, and it sends those signals to the brain, and the brain gets turned on saying, I'm having a migraine attack. But then the brainstem turns off, and then your migraine attack should be over. But what happens in people who have chronic migraine or chronic pain is that brainstem gets stuck in this on position. So instead of it being turned off and you no longer have the pain, it's stuck on, and it's producing these pain signals that are sending signals to the brain. I'm in pain, I'm in pain, I'm in pain. And then you're in this aberrant or loop of pain that shouldn't really be there.
Such a good explanation of that. And we know that at CHIP, when the pain signals get turned on, they just don't always turn back off. So is that, when we see that happening, is that something that as a doctor through testing, oh, you've got this pain signal that's turned on and your body is not turning it back off? Here are the things that we can do. Is that the time where you would administer a particular medicine, or say, here are the things if you could talk a little bit about what would your remedy be at that point, knowing that that's the case, that the pain signals are stuck on, or more wanting to be on than off?
Absolutely. So once you're in that chronic pain cycle, it definitely influences how I think about treating somebody in that situation. Because oftentimes what is the most effective when you're in a chronic pain situation is turning off the brainstem through non-medication interventions. So we know that if you can activate certain parts of the brain through non-medication things like relaxation training or relaxation strategies, exercise, all of those things will produce these downward pathways from the brain itself down to the brainstem. And we call these superhighways. And if you can create these pathways in your brain, it can actually turn off the brainstem and flip it back into a pattern where it goes on and off, instead of being stuck in the on position. So it's very interesting because it's these superhighways. I guess one thing that I should say before even any of this is that, especially in children and teens, their brains are extremely plastic. which means that you can actually change somebody's brain and the wiring in their brain. And that's what we're doing when we're utilizing these strategies. So right now, if you're in chronic pain, you're stuck in this on position. And then by using and activating these other parts of the brain to create these new connections, these downward superhighways, through daily practice, it can turn that off. But it's like creating muscle in any other part of your body. So, if you are trying to build muscle for some sport, that you are doing like weight training or things like that, and you're practicing it regularly to build up the bulk of your muscle and become stronger. And it's the exact same thing when you're building these connections and new connections in the brain. It's not something that happens right away. It's not going to happen overnight. It really is something that you need to do consistently and practice so that you can build these strong connections from the brain to the brainstem and help turn off this system.
This is the foundation of creative healing for youth in pain right there, is when the brain gets stuck in a particular place, typically pain, and then the body starts going into the whole anxiety, depression, the whole spiral of the comorbidities about this. That's exactly what we're doing. We're giving creative opportunities for the brain to do something different. And what you said is so important, which is this is not something that happens overnight. It's a slow dimmer switch. And so a lot of people think, okay, I meditated or I paused and I created this safe environment and I should be better. But it's really important to remind that this is a training program for a marathon, but it works. We've seen kids get out of bed that had chronic headaches, stomach aches, whole pain signals have been turned on. So I'm really grateful for that explanation, because I think a lot of people really benefit from hearing that this is something that's a highway that we can change the communication pathway within our brain, and not just for teens, correct? I mean, this is really
Exactly.
all of us.
Yes, exactly. Not just for teens, it can be for adults also.
And I love that, knowing as a parent that the neuroplasticity of the brain in teens and adolescents actually gives us the opportunity to have more of an effect, gives parents a lot of hope.
Exactly. And I've certainly seen many patients, as you described, who are in debilitating chronic daily pain. And by using some of these non-medication strategies, really have been able to disrupt that pain cycle and get back to the things that they enjoy. So there's definitely hope there.
And I think it's really important to talk about the fact that when people get a diagnosis, they feel like it's a lifelong diagnosis, that they're, especially with migraines. But the reality is, if you follow these instructions and you learn how the body works through doctors like you and through creative healing for youth in pain, you actually realize this does not have to be an affliction for a lifetime. This is something that can be course corrected.
Exactly. That's exactly right. And especially because migraine can affect kids who are very young. And so that's one of the things that we talk about, is that the trajectory of migraine can actually go a lot of different ways. And, learning these headache wellness strategies, learning these non-medication interventions for headache and migraine can really set you on a course that can be, towards getting back to all the things that you want to do. And it doesn't necessarily need to impact you lifelong. Certainly there can be times where there's ups and downs, but I think having the knowledge that you can do something about the pain when you're in a cycle that might be a little bit worse can be comforting to patients who have migraine.
And when we have a patient with migraine, right, they've been diagnosed, they have a migraine, they know it's a whole body experience. What's the first thing you say? I mean, obviously we're looking at medicine and non-medicine approaches. So I think it'd be great to take the non-medicine approach here. What are the first things we say about doing this so we can help these highways change? Is getting in bed with a dark room one of the first lines of defense, or is there things that you see that you would recommend different things for as a different approach?
Yeah, absolutely. So once you have the diagnosis of migraine, we talk about ways to manage and treat migraine. And that's this kind of multi-pronged approach. So the very first step for anybody who has a diagnosis of migraine is talking about lifestyle interventions. So lifestyle interventions, I like to think of them honestly as headache wellness, because I think that they are things that a lot of people could do even if they don't have migraine, and it would help them feel a bit better. So especially in people who have migraine, their body likes regularity. It likes a schedule. It likes things to be the same. So some of the things that we talk about at the beginning, once you have your diagnosis, is keeping a regular sleep schedule. So your body wants you to go to bed at the same time, wake up at the same time every day, including weekends. we talk about having an adequate amount of sleep and making sure the sleep you're getting is restful. So we talk about, doing good sleep habits, not using screens before bed, so that your body is getting prepared and relaxed to promote sleep. So that's one big area that we talk about in migraine is sleep. The next thing that we talk about for headache wellness is having regular meals. So people with migraine, their body likes to have their kind of glucose and sugar levels be more consistent throughout the daytime. So that's making sure you're having 3 meals a day, potentially having snacks if needed. And in teens, especially making sure that they're really having something for breakfast. That's a common one that kids will skip because they feel like they don't have time to eat breakfast before school. But having regular meals throughout the day is helpful. Making sure that a child is adequately hydrated throughout the day. So making sure that they're drinking water in the morning, have access to water while they're at school, and increase in the amount of hydration if they're doing anything, any sports or activities that include exercise. Exercise itself is actually really important for headache wellness. So we know that if somebody exercises for at least 30 minutes a day, 3 to 4 times a week, doing something that gets their heart rate up, that can be helpful in reducing migraine attacks. It also is helpful in stress reduction. And we know that stress can also be a contributor to migraine. As part of headache wellness, we talk about stress. So stress is very common in people who have migraine. And stress is actually quite interesting because when somebody is feeling stressed, it can contribute to triggering a migraine attack. So we know that when somebody is feeling stressed out, one of the first things that happens is their muscles become very tense. And when they're holding that tension in their muscles, then that can evolve into the autonomic nervous system getting activated. So when they're stressed out, they'll feel, their heart starts to race and things like that. And then once that autonomic nervous system is activated, then it can produce a migraine attack or headache attack. So utilizing non-medication strategies when somebody is starting to feel stressed out can actually be very effective in treating migraine. So as soon as they start feeling those symptoms of stress, in their body, using things like deep breathing or relaxation strategies can help calm the autonomic nervous system back down and prevent a migraine attack from happening. And then chronic stress is also interesting because not only can individual stressors kind of trigger a migraine attack, but if your body is under chronic stress, it can, like we talked about at the beginning, can kind of activate those chronic pain pathways and flip you into more chronic pain as well. So those are kind of like the crux of the lifestyle interventions. So we talk about sleep, we talk about meals, we talk about hydration, we talk about exercise, we talk about stress. And that's the first line intervention for anybody who has migraine. And interestingly, I'm only going to talk about probably 2 clinical trials during this talk, but one of them is, I think, really important. So it was a clinical trial that they looked at. So there were different arms to the study. So in the first group, it's children and adolescents who went on medication. So there's a few common medications we use in migraine for migraine prevention. So migraine prevention means a medicine that you would take every day to try to help bring down the frequency of migraine attacks. So in this trial, there was group 1 that went on amitriptyline, which is one of those common migraine preventive medications. Group 2 went on topiramate, which is another very commonly used migraine medication. And group 3 was the placebo group. So they didn't go on any medicine. They were just taking a pill that was a placebo pill. And during the trial, every single participant would go to a visit and they would talk about headache wellness and lifestyle interventions for a headache. So you would, no matter what group you were in, you would go and have your clinic visit and they would make sure that your sleep was good. They would talk about stress strategies, all of these different headache wellness things that I touched upon. And at the beginning of the trial, they looked at how many headache days everyone was having. And at the end of the trial, they looked at how many headache days everyone was having. And what they found was that there was actually no difference between the 3 groups. So it didn't matter if you did amitriptyline or topiramate or you did placebo. And it wasn't that nobody in the trial got better. It was actually that all 3 arms got better. So they're about 60 to 65% in each of these groups had a reduction in the number of headache days that they were having. And so there's been a lot of discussion and talk about this trial. It was published about 5 years ago now, about what does this mean? You know, we have these medications that we use. Are they really working? Like now we have placebo group that did just as well. And what we kind of all agreed upon was that it was these lifestyle interventions that were happening alongside the medication or the placebo that were really, really effective. So instead, what used to happen, maybe 10 years ago, was that if somebody had very persistent or chronic headache, the first step was be putting them on medicine. But now what we've come to realize is that all of these headache wellness opportunities and lifestyle interventions can make a huge difference in the number of headaches that somebody is getting. So because of this trial, that's always the first step that we do. And we really, really emphasize doing those lifestyle interventions because we have great data to support that by just doing those lifestyle changes, you can have a significant reduction in the number of headache and migraine days that you're having.
That's an incredible trial. And it just goes to show you how support and being heard, right? And our autonomic nervous system, again, because I always come back to autonomic nervous system, being heard, being felt, being seen, right? Being supported was the same as a medicine, which is phenomenal. And I love that that's a first line of defense. I mean, it's important, I think, right now to talk about, I know we're talking about medicine and I'd like to come back to medicine, but with the autonomic nervous system, you know, we're seeing so many people, young adults, teens, you know, post-pandemic coming out and having different somatic responses, having true physiological responses, and having these disease-like experiences that those of us doing this work know there's supportive measures that can help before you get to a place where you have to go to a different level of medicine. And so if you can talk a little bit about that. I know we've talked about the autonomic nervous system before, but more in terms of stress and lifestyle now that we know that that's one of the most important things we can do.
Absolutely, yes. I think that so lifestyle interventions are extremely important and are very evidence-based based on that trial. The other, just as important, and maybe honestly even more important, is talking about cognitive behavioral therapy for the treatment of migraine. So the other trial that I would like to talk about is a trial that looked at this. So in this trial, they had a group of kids who did amitriptyline, so that daily medicine to try to prevent migraines from happening, and headache education. So that's the lifestyle interventions that we talked about. That was group one. The second group did amitriptyline, the migraine preventive medication, plus cognitive behavioral therapy. And they did the same thing where they looked at how many migraine and headache days were the participants having before and after these interventions. And what they found was that the group who did the amitriptyline plus cognitive behavioral therapy, or CBT, that group did better. So they had fewer migraine days at the end of the trial compared to the participants who just did the medicine and the headache education. So what this tells us is that cognitive behavioral therapy gives you that extra boost. So cognitive behavioral therapy, I think, is a very, very powerful tool in people who have chronic migraine and chronic pain. And cognitive behavioral therapy is kind of a broad term that we use and can be used for a lot of different things. So you might have heard of people doing CBT for anxiety or CBT for other mood disorders. But the way that the CBT was used in this trial was specifically to pain and specifically to migraine. So it's a little bit different a little bit different compared to what's being done for mood disorders. And I think that's an important distinction because a lot of times when people hear like, oh, cognitive behavioral therapy, they automatically will think that, oh, I'm going to be doing therapy for a mood disorder. And maybe you don't identify that the mood disorder is a big contributor to your experience of pain. So what this trial did was it was looking specifically at cognitive behavioral therapy for pain and for headache. And cognitive behavioral therapy has a lot of different parts when you're using it for chronic pain and migraine. So the first thing that oftentimes CBT will do is helping patients understand problem-solving skills specifically related to their headache and their migraine. So how can you make sure that you're having a good breakfast, and how can you make sure that you're drinking water throughout the day when maybe your school is telling you, oh, you don't like the lunch at school, or they don't offer the vegetarian option for you. So kind of problem solving around different things that we know can influence and impact headache. It's kind of one part to it. Another big part is relaxation strategies and how to calm down the autonomic nervous system. So as we've talked about a lot throughout this webinar so far, is people with migraine and chronic pain, their autonomic nervous system is so revved up that it makes it easy to flip into those migraine attacks. So by using relaxation strategies to calm your body down and calm down the autonomic nervous system, you can really make a big impact on your overall well-being and the threshold at which you would get a migraine attack. So a lot of times my patients will tell me, you know, I can't go outside anymore because the light will trigger a migraine. And oftentimes it's because you're in this revved up cycle and pain cycle. And so if you can use things like cognitive behavioral therapy and relaxation strategies to calm that down, then the idea would be you would be able to go out into the sun and not have a migraine attack get triggered because you have recalibrated where that threshold is to kind of flip off a migraine attack. So cognitive behavioral therapy is probably the best therapy that we have to treat migraine in teens and children.
And does that require a diagnosis and a prescription, or is that something that parents can find in their area, you know, find a really well-trained person to do that? Do they need a prescription, or is that something they can find on their own?
Yeah, so you don't need a prescription for it. Parents can identify therapists that are in their local area to do cognitive behavioral therapy that way. There is a paucity of providers, so it's one of the biggest barriers, I think, is being able to find a clinician who is trained specifically in pain psychology and has that background to be able to provide that type of cognitive behavioral therapy. But there's a lot of different ways to access it. So, you know, you can go through your pediatrician's office, and a lot of times they have therapists who they've used or worked with in the past that will come recommended. You can use like online resources to identify therapists who are trained in specific areas, like search engines, and that will give you a list of therapists that are nearby or in your area. There are also some advocacy groups that will do kind of group therapy, and a lot of them are online, so you can participate in like webinars or other kind of virtual ways to do cognitive behavioral therapy and group therapies. So there are a lot of options, but finding a person who is trained in what you're looking for and in your area can sometimes be a barrier.
And thank God for the Zoom era that we now have at least some more options. You know, I really want to go back to what you said, because this is such an important concept that I really want to revisit this, right? This is about how our body perceives stress. When this child said to you, I can't go outside anymore because it's too light. And your response is, well, we have to give you some things to do so you know that you can go outside and not get worse. Because once that anxiety sets in, now we have these two things that both are feeding on the autonomic nervous system, and now the body has to work harder to get around it.
Yes, absolutely. And I think this is a good time to talk about how pain is really this biopsychosocial experience. So historically, we have thought about pain in this very linear fashion where there's, you know, something physiologic or something happening in the body that is causing pain, and that is the only thing that is contributing to somebody's pain. But as we've learned more, we've come to understand that it's so much more complicated than that. So the experience of pain is biologic. So that physiological change in the body that is producing pain is very much there. But then you have this psychosocial experience of pain. So, you know, if we take each of those words, so psychological, so that's things like, do you also have anxiety or depression or other mood disorders? Because we know that in people who have those mood disorders, their experience of pain is actually very different from somebody who might not have those comorbidities. And then the social aspect to it, you know, what are your support systems? What is your social environment like? We know that those can also contribute to how somebody experiences pain. And there's a lot of interesting research that's coming out about how childhood adverse experiences can influence pain and head pain and migraine, and how that's an extremely important part to chronic migraine and chronic pain. And I think it's an important aspect when we're talking to patients who have chronic pain and chronic migraine is talking about the physiological aspect to it, but then also the psychosocial experience of pain. And, one thing that can happen is this pain catastrophizing. So, a patient will tell me that, every time they go outside, they get a migraine. Every time they go to school, they get a migraine. And the pain is so bad that they can't get out of bed. They have to lay in a dark, quiet room until the pain passes. And it feeds into this pain catastrophizing. And when that happens, you're just reinforcing these networks these chronic pain networks. And it's making it really, really, really hard for your body to kind of flip out of those chronic pain cycles. So one of the things that I will talk about with my patients is, how can we get you back to where you were before and regain some of the function that you lost by going into this chronic pain cycle? So one of the big ones that comes up is school. So, how do you get somebody who hasn't been to school in weeks or months back into school and feel confident and comfortable that they can be there? And part of that is talking with them about the difference between protective pain and non-protective pain. So if you think about protective pain, that's something like you go outside and you roll your ankle and you sprain your ankle. And that acute pain that you're having is what we call protective. So your body is telling you that you should not walk on that ankle, because if you do, your pain is going to get worse and the ligaments and muscles are going to be more damaged. But once you're in chronic pain, that pain is no longer protective. So there's this fear that, if I go to school, my pain might get worse, or I might make my migraine worse. But that's not protective pain anymore. When you're in this chronic phase, it's non-protective. So your body is telling you that you're in pain, but it's not that if you are, pushing yourself to go to school, it's not that is, your body telling you that you can't do it. You're in this aberrant cycle, and we need to kind of help support patients through that and give them the confidence that they can go back to school. And even if they're having pain, it's okay to push through the pain a little bit. And there's this idea of pacing, because what ends up happening is that, they'll go back to school and they'll try to go for a full day right after being out of school for months. And then you have this huge setback, right? Because your body is not used to that. So it's not realistic to go from 0 to 100. So there's this idea of pacing where you want to start going back gradually. And oftentimes we talk about a, school reentry plan. So, maybe it's that you go to school for 1 hour a day, and you do that and you build up the confidence that you can do an hour at school. And then, after a couple of days of doing an hour, you do 2 hours. And then you slowly work your way up to having full days in school. And, it's the idea of pacing is even on those days where you are feeling like you cannot go, you still get up out of bed and you go for at least that hour. And getting back into those routines can actually be extremely helpful and help get your body out of that chronic pain cycle and get you back into those biorhythms that we know can be protective in people who have pain.
I mean, it really is reminding everybody to be a partner with your autonomic nervous system, right? Because we know the pain is a process. It's almost a trigger, right? It's been triggered on. So it says, oh, every time I go out that door, I'm going to trigger back on. I'm going to flip the switch. The pain comes on going out the door. But each time you go out the door, even if you step on the other side of the door, you're reprogramming your brain to remind itself, you know what, I'm okay. And you were talking, and I just kept feeling these pediatric pain rehab programs and how they really are based on a 21-day reset. But we have this power to do this at home with these little baby steps that you're talking about, and working with the school and having a safe place. So if you could take a few minutes to talk about what do you recommend for parents to do with schools to say, okay, my child's coming back. However, we're in a training program. We're not going to run this marathon today.
Exactly. And working with the school is so important. And there's a lot of different ways that you can support kids on their reentry into school. And a lot of things that you can do, even in people who have migraine and maybe are just missing a few days here and there of school. I think that these principles can apply to both situations. So for, school reentry, it's a lot about working with the school to tell them that it's okay for them to be there for an hour, that they, that's part of their plan. Their pain plan and their rehabilitation plan is to be in school for at least an hour every day. But what that looks like for them might be a little bit different for everyone. So oftentimes there's a lot of triggers at school, right? Like there are bright lights. Fluorescent lighting is something that I hear over and over again as contributing to worsening pain and migraine attacks. It's really loud. It's like a bustling environment, and that can trigger attacks. They're getting up early, which also can trigger attacks. So there's all of these things that can make school just a place where migraines can happen. So making sure that the child has access to a cool, dark, quiet space. So if their pain were to get more intense or they were to be having a migraine attack at school, allowing them to rest in the nurse's office in this environment to kind of help calm everything down. They can, use ice and heat and relaxation strategies in that room, and then allow them to return back to their class. I think that, making sure that they have access to like snacks throughout the day in case they were to need that, allow them to carry a water bottle at school. Some very basic things like that can be helpful. And then in terms of the school assignments themselves, oftentimes allowing children to have a little bit extra time on assignments or on tests can be helpful. Coming up with a makeup plan for work that they've missed can be helpful, because oftentimes the stress of missing assignments and then feeling like they're so far behind that they'll never be able to catch up just makes the task so daunting. So if you can come up with a makeup work schedule so that they know which assignments they need to complete and when they need to be completed by, that can be helpful as well. And then for patients who have these more like episodic migraine attacks, making sure that they have access to their medication that they use to treat their individual headache attacks at school can also be helpful, so that they can treat their headache in the moment and then return to class after the migraine has subsided.
And before I ask this next question, I want to reiterate the fact that we know pain is real. Pain caused by anything is still real, whether it's somatic, whether it's emotional, it's still real pain. And so my next topic is really when we see our children and pain as an avoidance, as a parent, what do we do with trying to remind our children, right? We want to acknowledge their pain, but we also want to help them with the somatic piece and pain as an escape, because pain now is a trigger based on the perceived stress at school.
Yes, exactly. And that is such a complicated place to be in as a parent, because it's probably one of the hardest things I hear is to watch your child be in pain. So when they're having this, severe pain episode, how do you support your child through that pain episode, but at the same time, encourage them to be able to make steps towards regaining function? So I think there's a couple of different ways that parents can do that. I think the first step is acknowledging that they are in pain. So saying to them, I know that this is really hard. I know that your body is in pain right now. I think that, one of the things we can do is to stick to our plan that we had talked about. And I know that school is a trigger for you, but we're just going to go, and you're going to be safe there, and you're going to be there for just an hour, and then you're going to come home and, you can relax and reset. So I think that validating their experience is extremely important, but then giving them gentle encouragement that it's okay to push through the pain and stick to their treatment plan that they came up with their school, with their doctor, and that it's important for them to stay on their plan even on days where they're feeling like they just can't do it.
It's so important. We've seen it time and time again with Chip, with our kids that are bedridden, and they say, I can't even, I can't go down to the kitchen, it hurts too much. But eventually, not only do they go to the kitchen, they go back to school, they go to college, but it is this long process of every day encouraging kids to get out of bed, do something that even is 1 foot past what you did yesterday. Doesn't have to be 10 steps, just 1 foot, just to gently ease. And what you said about going to school, I mean, I know some kids have to do drive-bys to school to eventually get on campus, to eventually get through one class or whatever, and having that partnership with the school is so important. But what you said earlier is the most important, which is please don't go a whole day, your first day out.
Exactly. And we talk about this with exercise too, because that one is a huge barrier. Kids will say, there's no way I'm going to be able to exercise because they've been in pain for so long. And it's the same thing. It's this, we call it, a graded exercise plan. It's if you haven't been outside or you haven't moved your body in months, there's no way you're going to go out and run, right? Like that's just not realistic. So it's literally coming up with a plan that works for them. So if they think they can walk 10 steps and that's it, that's where you start. You start by walking 10 steps and you do that every day. And you build up your confidence and your knowledge that you can do it. And then you build on that. So, you go from walking 10 steps to walking 15 steps, and from 15 steps to 20 steps. And, that building that up is such an important part to, getting them back to being able to function and do all the things that they like to do. Oftentimes these are kids who were, athletes or used to be able to dance and play sports, and now they haven't been able to do it in months and months. So, working back towards that goal can sometimes be helpful too, knowing that that is the goal. We're going to get you back to where you were. It just is these very slow baby steps towards it.
And as you were talking, I realized that so often kids are thinking about the pain returning as opposed to being out of pain. And that thought process that lets you stay out of pain is embodied in that process, right? We're fearing the pain. So we're concentrating on the very thing we want to avoid.
Exactly, exactly. I know. And then you just get stuck in this cycle of worrying about the pain and, oh my gosh, if I do this, then the pain's going to come back. It's going to come back worse. I'm going to have a setback. So it's all connected. The way that you think about pain, the way that your body experiences pain, it's all very connected, and the relationships between them are so important.
And reminding the body that we're safe. And we're not just safe in bed, or we're not just safe at home, but we can be safe at the front door. We can be safe in the next steps, and just kind of rephrasing the focus while I know I can hear the teenagers say, but I'm going to be in pain. And you say, but we're going to try, because we're on a training program and we're all in this together. And, I know that there are headaches or migraines that are not just in the head. There's also abdominal migraines. And, sometimes we're seeing the stomach ache and the headache, but what is an abdominal migraine? And what's the difference between abdominal migraine and just your stomach? Because now you've been so nervous because you're always focusing on pain.
Yes, that's a very good question. So migraine is actually quite interesting, because we think that migraine is an inherited disorder, which means that there are genes that put you at higher risk for migraine. And the way that the genes are expressed depends on the environment in which you're in. And then it kind of also depends on how old you are. So depending on how old you are, your migraine genes get expressed in different ways. So what we see is even like little tiny babies who have these migraine genes, if they get turned on, it can manifest as what we call infantile colic, which is when a baby has excessive crying and is extremely fussy. And as kids get older, the migraine genes might come on as something called like vertigo, where they have these periods where they're like super off balance when they're a toddler and they look like a little bit scared. And then as they get older, it can turn on to something called abdominal migraine. So we think of these things as these kind of precursors to migraine, or childhood periodic syndromes is another term that we use in the medical field. And so when you get to kind of around pre-adolescent age, that's the time where we're seeing a lot of abdominal migraine. And abdominal migraine is this feeling of poorly localized, diffuse pain in your stomach that comes on and comes off, kind of like a migraine attack would, but the head pain is not the most prominent feature. So it's really the abdominal pain that is the most prominent feature of abdominal migraine. And, we think about abdominal migraine like very similar to how we think about more traditional migraine. And we treat it in a very similar way also. So, you can treat these kind of discrete attacks of abdominal pain with medications that we would use for more traditional migraine, and non-medication things that you could also, that we use for more traditional migraine, you can use them in abdominal migraine. And oftentimes kids who have abdominal migraine will then kind of go on to develop more kind of quote unquote classic migraine with more prominent head pain features to it. So that's kind of what abdominal migraine is, but it can be very hard to tease apart, because as we know, in people who have chronic migraine, when their pain becomes more persistent, those associated symptoms can, spill out into other areas. So, you have kind of more chronic nausea, chronic abdominal pain, And it's not necessarily, distinct abdominal migraine at that point. At that point, it's more of these associated symptoms have, gone out into other times, even when you're not having a discrete migraine attack. So, like we've talked about, when the autonomic nervous system is super revved up all the time, those symptoms are there all the time instead of just during these discrete episodes of migraine attack.
I guess it's just important to remember that it's the same process, feeling safe and knowing that the whole body feels like it's not safe, and to remind it is safe, and to do these other exercises, regardless of whether it's in the stomach, in the mind, in the brain, or however the body's responding. These same techniques work in addition to medicine if that's what's required to help the body reset the pathways. Is that the best
Exactly.
way?
Yes, exactly right.
And in regards to traditional medicine, I know you mentioned the two in the clinical style and trials. Is there any other medicines that are newer on the horizon, and different ways of treating it from when we realize we have to go in and help the body change that pathway of pain?
Yeah, definitely. So when we think about how do we use medication for the treatment of migraine, there's kind of these two big classes. So we talk about acute medicine. So that's the medicine that you would use to treat an individual migraine attack. So those are just as needed. It's like, okay, I'm having a migraine attack. I need to go get my medicine and take those to try to make the headache go away, or the migraine attack to go away. The other category is called preventive medication. So that's something that you would take every day to try to prevent the headache attacks from happening. So for the acute medications, the ones that are used most commonly are, like, first line is going to be an NSAID. So that's things like ibuprofen, Motrin, naproxen. Those are great migraine medications. So you would take those when you start to feel like you have the head pain. That's one class. The other very migraine specific acute medication is called a triptan. So triptans are great migraine medications. They're one of the only medications that we have that was designed specifically to treat migraine. So it's not used for anything else. Like, obviously, Motrin and Advil are these general medications that we use for a lot of different things, whereas triptans are really only used for migraine. So triptans, if you were to feel a migraine attack coming on, when the pain is still in this mild phase, that's when you take your triptan, and it should help stop the migraine attack. And you can use your triptans with the Advil or the other NSAIDs. And that's a very common regimen to have for treating acute migraine attacks. So it's important to have a good acute medication, because that gives people confidence that, if I'm out with my friends and I start to feel a migraine attack, I have my acute medications that I can take in the moment to try to bring that pain back down. So that's one type of treatment. The other type of treatment is this preventive medication. So those are the medicines that you take every day to try to prevent the headaches from happening. So the three most commonly used medications are amitriptyline, topiramate, and propranolol. All three of these medications are old medications that were designed to treat something else. So amitriptyline is a tricyclic antidepressant medication. So historically has been used to treat anxiety and depression. Topiramate is an anti-seizure medication. So historically is used to treat epilepsy in people who have seizures. And propranolol is a beta blocker, and historically is used to treat people who have high blood pressure. However, we know that those medications actually can reduce the number of headache attacks and migraine attacks, and the severity of attacks that somebody gets. So we do still use those medications. And the idea is that you're kind of calming down your system and making it harder for you to have a migraine attack. So we talked about, going out in the sunlight and it triggering a migraine attack. So part of the reason why we use some of these preventive medications is that it just keeps everything a little bit quieter so that you can do those things and not flip over into a migraine attack. So those are like the very basic type of medications that we use. I should say that the only one that is actually FDA approved for use in the pediatric population to treat migraine is topiramate, but we do use those other ones very commonly to treat migraine. And then the new medications are quite interesting and very exciting for people who have chronic pain and chronic migraine. So there's a new class of medications. They're called CGRP, calcitonin gene-related peptide medications. So CGRP is one of those pain molecules that gets released during a migraine attack. So if you remember to the very beginning of this webinar, when I was talking about, the peripheral nerves getting activated and releasing these pain-producing substances, one of those is CGRP. And there's decades of data to show that when someone has a migraine attack, CGRP gets released. And so if you have medications that block the CGRP, it can prevent migraine attacks from happening. So these medications are brand new. They were approved for the use in adults, so 18 and over. The first one came out in 2018. And these are very interesting medications because they are used both for migraine prevention and for treating individual migraine attacks. So for prevention, there's CGRP monoclonal antibodies. These are once a month injections that a patient will give themselves at home. And it blocks CGRP. So it either binds to the CGRP molecule itself or it binds to the receptor, and it prevents the CGRP from getting released and producing a migraine attack. And then there's also ones that you can use in the moment. So if you were having a migraine attack, you could take one of the CGRP medications and it would bind to the CGRP and try to prevent the attack from progressing. So the reason why these are like so cool and so exciting is because these are really the first, besides for triptans, the first targeted migraine treatments that we have. And unlike triptans, we can use them for prevention. So, amitriptyline, propranolol, topiramate, those were all created for something else, and we figured out that they were helpful for migraine. But these CGRP medications are truly designed to treat migraine. So they are very, very targeted. And so right now we are using them kind of off-label in the pediatric population since they're only approved for 18 and over. And there's many clinical trials that are ongoing to look at their efficacy and effectiveness in the use in the pediatric population.
No, this is amazing and so much great information. And I think it's important for people to recap the things we've talked about really in the fact that, yes, there were these studies. We saw that there was the placebo that matched these traditional meds, but to remind everybody, right, that when you have support, whether it's medicinal support, CBT support, familiar support, school, working together, they all work. But we just have to remember it's a slow process to retrain the brain. And as I'm seeing some of the questions, right, it's important for everybody to understand that there's all these different things, but it comes back to reminding the body it's safe. And so that the nervous system says, okay, I'm safe. But if you've already triggered your pain pathway, you can still feel safe and still have a migraine. And so we can bring in medicine or different things at that point. And I'm seeing one question about intractable migraines besides lifestyle changes, which is a perfect question right after what I was just bringing up as our last question before we close out today, if you wouldn't mind talking about when that pain process becomes intractable.
Yes. And is the question how to manage it?
Yes, because we now know that we've got the pain process triggered. We've got medicines, but now it's intractable. What
exactly?
Is this the marathon? Is it a combination? What do you recommend?
Yes, absolutely. And so I think there's a lot of ways that you can treat the intractable pain. And oftentimes it is this multi-pronged approach. So it's lifestyle interventions, it's CBT, and then it's also layering in the medications. And one thing that I think is really interesting about treating headache is you have this toolbox, and oftentimes there's not a one treatment plan fits all, and it's really tailoring and individualizing the treatment plan to that specific patient. So, I think there's a lot of different ways that you can attack it. You can go down, you can try different medications. Sometimes, just because one medication didn't work doesn't necessarily mean another one won't work. And you can try to see if there's a medication that helps kind of bring down that threshold. But oftentimes you need to layer in the non-medication interventions as well. So you often will do medication for intractable migraine, but then you'll also do CBT and relaxation training and things like that on top of it. But there's definitely a lot of ways to treat migraine and a lot of options. And you kind of are pulling out of the toolbox different things and then individualizing it to the specific patient.
This was an amazing amount of information. And I know that a lot of people have said, I want my child to watch this. So I just want to thank everybody. And I want to remind everybody that we do tape all of these. These are put up on YouTube. If you go to YouTube and go to Creative Healing for Youth in Pain, you can also go to mychip.org and find all of these recordings on a variety of things, but especially today's, which was so helpful in the way you presented the information. I feel like a lot of parents are going to feel empowered now to say, okay, the pain's real, and we need a toolbox, and we have these baby steps and a partnership. And so thank you for really reminding everybody we have more say in our bodies than we think. And we have medicine to help us along the way and a whole process. So I can't thank you enough for the abundance of information and, reporting on some new clinical trials, which I think is always giving us optimism and hope, which sometimes that's all we need is a little hope each day. Thank you for everybody who joined us today. If you found this inspiring and you feel like you would like to help CHIP and help what we do in the world, please go to mychip.org and you can make a small donation just in gratitude of these programs and for the doctors that provide such great information to all of us. I know you have such a busy schedule, especially as a neurologist, and we are incredibly grateful for your time today and allowing us to ask you question after question. So thank you, Dr. Shapiro. Thank you for CHIP, and thank you for everybody for joining us today. In the interest of time, I've hit 11 o'clock sharp. I really try to be respectful of that. We went down to the minute. I know we could have kept talking. So thank you all for joining us today. We look forward to seeing everybody next month. And Dr. Shapiro, thank you as always for all
Thank you for having me.
Thank you. Everybody have a wonderful day, and remember your toolbox.